Welcome to the deep dive. Today, we're diving into something really common and often quite debilitating, lower back pain.
That's right.
Specifically, we're looking at lumbar disc herniation, or LDH, and, that related thing, sciatica, that pain shooting down the leg.
Yeah, it's incredibly prevalent.
It really is. The sources mentioned it accounts for maybe 2/3 of all spinal pain diagnoses, and sciatica hits, what, 1 to 5% of people every year?
Something like that, yeah. Huge numbers. And, the interesting thing about LDH is, while surgery is definitely an option, sometimes for faster relief,
Right.
the body itself often does a pretty amazing job of healing.
Yeah.
The research shows quite clearly that without surgery, that herniated disc material can actually shrink or just, well, go away on its own.
Yeah, I was looking at those stats. It's quite striking. Something like 2/3 of patients without surgery see the disc physically regress on scans.
Exactly.
And even better, symptom-wise, about 85% find their symptoms just resolve within a year.
85%. It's a big number. It tells you that, for the vast majority, time and conservative care can be really effective.
Okay. But that leads to the massive question, right? Like, if most people get better anyway, how do you know if you're likely to be in that group? How do you make that call?
That's the core issue, isn't it, for patients and clinicians? Which is why, for this deep dive, we're focusing on a really significant piece of research. It's a systematic review and meta-analysis.
So, like a study of studies.
Precisely. Pulling together data from lots of different studies to find the patterns. And this one looks specifically at predicting, whether a herniated lumbar disc is likely to regress spontaneously.
Okay. So, our mission today, unpack that big review. Figure out what the science says about the factors that predict spontaneous healing. Giving you the clearest picture we can, let's get into it.
Right. So first off, to understand the predictors, we probably need to be on the same page about what LDH actually is. The classifications used in the research, often the NAS ones, the North American Spine Society,
Yeah.
they define it based on sort of the shape and location of the disc material that's moved out of place.
And there are different types, I gather.
Yeah, exactly.
Yeah.
The morphology, the form. First up is bulging. This is usually a broad-based extension, typically pretty small, maybe less than 3 millimeters.
Okay.
Sometimes it's even considered, just normal wear and tear.
Right.
Then you have protruded. This sticks out more, over 3 millimeters. But critically, the base, where it connects to the main disc, is wider than the bit sticking out.
So it's pushed out, but still broadly attached.
You got it. Then it gets more serious. Extruded. Here, the bit sticking out is wider than the neck connecting it back, or it's pushed through ligaments, often that posterior longitudinal ligament, the PLL. It's gone further.
Oh, okay. Extruded.
And finally, sequestered. This is a type of extrusion, but a piece has completely broken off. It's detached. A free fragment just floating in the spinal canal.
Wow. Okay. Bulge, protruded, extruded, sequestered, detached. So the big shocker from the meta-analysis was how much the type predicts if it'll go away on its own.
Yeah, this is probably the headline finding. The study actually put numbers on the probability of seeing any regression, any shrinking at all on imaging. And it's not what you might guess.
Go on.
For bulging discs.
Yeah.
Only about 13% showed regression.
13, okay, low.
Protruded discs, better, around 53%.
Half.
But then extruded discs, over 70% showed regression.
60%.
And sequestered the completely broken off bits. An amazing 93%.
93. That feels totally backward. The fragment that's completely broken off is the most likely to disappear.
It does seem counterintuitive, doesn't it? But the data was really strong. Highly statistically significant, that p-value less than 0.001.
Meaning very unlikely to be chance.
Extremely unlikely.
Yeah.
And when they compared extruded and sequestered together, let's call them ES versus bulging and protruded BP, the ES group was over 4 times more likely to regress at all. The odds ratio is 4.3.
4 times the odds. Okay, that's for any shrinking. But what about vanishing completely? Like full resolution on the scan?
They looked at that too. The numbers for complete resolution are lower overall, naturally, but trend exactly the same.
Okay.
Bulging, about 11%, completely resolved.
Even lower, maybe 7%?
Jumps up to around 31%.
Almost half, 49%.
Nearly 50% of sequestered discs just gone.
Yep. Again, highly significant statistically. Sequestered discs were actually twice as likely to completely resolve compared to extruded ones. Odds ratio there was 2.13.
Wow.
And overall, the ES group, extruded and sequestered, almost 5 times more likely to completely resolve than the BP group. Odds ratio of nearly 5.
So the message seems pretty clear.
Yeah.
If you have an extruded or especially a sequestered disc, the odds of it shrinking or even totally disappearing on its own are way higher than with a bulge or protrusion. Did they say how long this takes?
Yeah, they did calculate a mean time for a complete resolution. It was around 10 months.
10 months. Okay, that's still a decent wait if you're really suffering.
Or-
So morphology, the type is huge. What else did they find? Were there other predictors?
Absolutely. The analysis dug into other quantitative factors.
Like what?
Well, one was the baseline volume, how big the herniation was to start with. And again, counterintuitively, the discs that did regress were significantly larger on average at the first scan.
Bigger herniations regressed more.
Yeah, significantly larger. We're talking an average of over 1,200 cubic millimeters for those that regressed versus around 1,000 for those that didn't.
Okay, well,
Then there was the ligament thing. Remember that posterior longitudinal ligament, the PLL?
yeah, the man at the back.
Right. Whether the herniation broke through it, which is called transligamentous, or stayed under it subligamentous, the transligamentous ones, the ones that broke through, were significantly more likely to regress.
So getting outside that boundary seems key again.
Seems to be. And they also looked at something called Komori type. It's just another classification, considers size, and also if the fragment has migrated up or down the canal.
Okay.
And guess what? Higher Komori types, which usually mean bigger or migrated herniations, had much higher regression rates, like 27% for type 1, jumping to over 70% for type 3.
Consistent pattern then.
Yeah.
Bigger, more broken off, more migrated, more likely to regress. Did they look at the bones themselves? Any changes there?
They did. They looked at modic changes. These are signals you see on MRI in the bone marrow of the vertebrae, right next to the disc. They can indicate inflammation or other stuff going on in the bone.
Did that predict regression?
So in the big meta-analysis pooling all the data, the result for modic changes predicting regression wasn't quite statistically significant on its own. The p-value was around 0.1.
Borderline, maybe.
Kind of borderline. But, and this is important, there was a consistent trend across many of the individual studies they looked at. The trend showed that when modic changes were present, regression was actually less likely to happen.
Less likely with modic changes. Interesting. Okay, so summing up the predictors. Bigger volume, extruded or sequestered type, breaking through the ligament, transligamentous, higher Komori type, and maybe the absence of those modic changes. These all point to a better chance of it going away naturally.
That seems to be what this comprehensive review suggests, yes.
But why? Why on earth would a bigger, more detached piece be more likely to just vanish? It feels wrong.
It does feel wrong intuitively, but the leading explanation makes a lot of sense. It revolves around an autoimmune response.
Autoimmune.
Yeah.
Like the body attacking itself.
Sort of, but attacking something it sees as foreign. See, the inside of the disc, the nucleus pulposus, is normally kind of hidden from your body's immune system. It's an immune-privileged site.
Okay.
When it herniates out, especially if it breaks off completely sequestered and enters the epidural space around the nerves, the immune system suddenly encounters this material it doesn't recognize. It sees it as foreign.
Oh, like an invader.
Exactly. And that triggers inflammation. The body sends in immune cells, especially these cells called macrophages. Think of them as like the Pac-Men of the immune system.
Uh-huh. Okay. Little cleanup crew.
Right? They engulf and digest the herniated material. It's a process called phagocytosis. The body is literally cleaning up the mess because it sees it as foreign debris.
Okay, that actually makes perfect sense now. The more foreign material that's exposed, the bigger the immune reaction.
Precisely. And that ties all those predictors together.
How so?
Well, larger volume, more material for the immune system to react to. Extruded or sequestered, especially transligamentous. That means the material is out in the epidural space, fully exposed to immune surveillance, not contained, stronger trigger, more macrophages, more cleanup.
Right, yeah.
And that finding about modic changes potentially meaning less regression. That might fit too. Modic changes involve bone and end plate changes, maybe more cartilage involved. Cartilage can sometimes dampen inflammation, so maybe less cartilage in the fragment means a less inhibited, more robust immune cleanup.
It's like the body has its own microscopic surgical team that gets activated when things break out of bounds. That's quite incredible.
It really is.
So this regression we see in the MRI scans, does it generally correlate with people actually feeling better? That's the goal, obviously.
Yes. Generally, the studies included showed that positive correlation. As the disc shrinks on the scan, symptoms tend to improve.
Good.
Oh, and there was another interesting point from the qualitative part of the review. Some papers hinted that a shorter duration of symptoms, maybe less than a year, might be linked to a higher chance of seeing that regression on the MRI.
Shorter symptoms, more regression seen.
Yeah, potentially. And that fits clinically too, right? People with shorter symptom duration often tend to do better overall, regardless of treatment path.
Makes sense. Okay, so the big picture is spontaneous healing happens a lot, especially with these specific types of herniations. We have good predictors now, thanks to this meta-analysis, morphology, size, location relative to ligaments, maybe modic changes. But that 10-month average time for complete resolution you mentioned,
Yeah.
that's still a long time to wait if you're in a lot of pain.
It is, and that's a key point the study raises. While knowing about overall regression is helpful clinically, what we often really need is to predict early regression. Like, who's likely to get significantly better in the first, say, 3 months or 6 months?
Why is early prediction so important?
Because decisions about interventions like surgery often need to be timely. Surgery tends to offer faster pain relief than waiting it out. And there's some evidence suggesting that if surgery is going to be done, doing it within maybe 6 to 12 months of symptom onset might lead to better long-term functional outcomes compared to delaying it much longer.
So you need to know early on if waiting is likely to pay off relatively quickly.
Exactly. The source did actually cite one study that tried to look at predictors of early resolution less than 3 months.
And what did they find? Anything different?
They found some anatomical factors seemed relevant, like the height of one of the vertebrae, the L4 posterior vertebral height, and the sacral slope that's about the tilt of your pelvis. Those, plus the larger initial herniation volume we already discussed, seem to predict quicker improvement in that specific study.
Interesting. So maybe anatomical shape plays a role in speed?
Possibly, yeah. But as the authors of the big review noted, there's still work to do. Different studies define things slightly differently, follow patients differently.
Yeah.
They call for more standardized research and definitely more focus on finding reliable predictors of that early regression to help guide those crucial, timely clinical decisions.
Absolutely. Well, this has been fascinating. This deep dive really sheds light on the body's ability to heal these herniations, and it turns some common assumptions on their head, doesn't it?
It really does.
We've learned morphology is key, bigger might actually be better for regression, breaking through ligaments is important, and the immune system is likely the star player.
Yeah, the main takeaways are pretty clear. The type of herniation matters hugely. Larger extrusions or sequestrations have a surprisingly good chance of resolving. Getting outside the ligament helps trigger it. And maybe those modic changes suggest a slower process. It underscores the body's incredible capacity.
It really does. So let's leave you, the listener, with a final thought. We've heard how these larger, more broken disc fragments seem to provoke a stronger cleanup response from the immune system, leading to better natural resolution. Thinking about that, what does it make you wonder about the immune system's role in healing other kinds of damage or dealing with foreign elements elsewhere in the body? What potential does that unlock in your mind? What stands out to you?